How's it going, guys? It is 4:07 a.m. Thursday, April 21st here in Japan, and we have a medium difficulty Neuro/Ophthal question. I will keep this explanation consolidated, not waste our fucking time. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. I really appreciate it. Find me on Instagram at Mehlman_medical, MEHLMAN_medical. Link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now let's start the question. 34-year-old man, 1 week history of visual disturbance in his left eye. Examination shows pupillary constriction when a finger is brought close to the left eye, but no constriction when a bright light is shown. Which of the following is most likely to be seen in this patient? So let's just walk through the answer choices here. Choice A, diminished pain and temperature sensation bilaterally. Wrong fucking answer. This refers to syringomelia, which is when we have a collection or cyst of cerebrospinal fluid that impinges on a structure in the spinal cord known as the anterior white commissure, which is the decussation or crossover point of the spinal thalamic tracts. So if you have loss of pain and temperature sensation bilaterally, it is going to be anterior white commissure as the answer. You need to be able to identify that in a 2D slice of the spinal cord on neuroanatomy. I've linked the high-yield neuroanatomy PDF in the comments below as a pinned comment. Very fucking excellent PDF, one of the most popular PDFs on my site. So anterior white commissure for bilateral loss of pain and temperature. If you have a unilateral loss of pain and temperature, you're going to choose the contralateral spinal thalamic tract, okay, on the spinal cord. Once again, neuroanatomy PDF is down below. Wrong fucking answer. Choice B, hyperacusis. Wrong answer. This refers to sounds being too loud. This is going to be an ipsilateral cranial nerve 7 lesion, facial nerve lesion. Not only will we have Bell's palsy, but also, so the entire half of the face cannot move, but also cranial nerve 7 innervates the stapedius muscle, smallest muscle in the human body at 6 millimeters. It normally prevents the stapes, one of the ossicles, middle ear bones, from contacting the oval window too strongly. So if you have a palsy of cranial nerve 7, you have too much activity of stapedius. What the fuck am I saying right now? If you have cranial nerve 7 palsy, you would have lack of innervation to stapedius, too much activity of the stapes, bone contacting the oval window, and sounds that are too loud, okay? Wrong fucking answer. Choice C, inability to adduct the left eye when looking to the right. This is wrong answer. This refers to medial longitudinal fasciculus syndrome, aka internuclear ophthalmoplegia. The description / discussion of this can get very fucking complicated very fucking fast, okay? This is pathognomonic for multiple sclerosis. In MS, you can get either optic neuritis, which is any change in vision, inflammation of cranial nerve 2, okay, such as central scotoma, which is loss of central vision, loss of color vision, change in visual acuity, or you can get internuclear ophthalmoplegia, INO, MLF syndrome. So the long story short is the side that cannot adduct is the side that's fucked up if you're forced to choose on a neuroanatomy slice. Essentially, when you look to one side, if we look to the right, we have to activate abducens nerve on the right, cranial nerve 6, in order to abduct the eye. But the left eye has to adduct via oculomotor nerve 3. So the MLF, medial longitudinal fasciculus, is a structure in the midbrain that allows for unison of cranial nerve 6 firing on one side with oculomotor nerve firing on the other side. So as I said before, it's the side that cannot adduct, that's the side that has the MLF that's fucked up. Okay, so if they tell you in the vignette that a 28-year-old woman with MS cannot adduct the left eye, you're going to choose, and they show you a weird structure of the midbrain, you're like, no idea what I'm looking at, you're going to choose the left side, and you're going to choose the most medial structure, which is the MLF. Wrong fucking answer. Choice D, intraocular pressure greater than 21 millimeters mercury. Wrong answer. This refers to glaucoma, okay? So in most cases. So this is not glaucoma. I mean, there's open angle, closed angle. Open angle will be painless, a loss of peripheral vision over many months or years. Closed angle will be a fixed, hard, red eye, midline dilated pupil, and you need to give topical pilocarpine, muscarinic receptor agonist, to increase tearing. Normal intraocular pressure should be 12 to 21 millimeters mercury. You're not going to get asked that range on the USMLE. I'm just letting you know. So tonometry is measure of pressure within the eye. Okay, so if they give you on step 2, for instance, what sounds like closed angle glaucoma, as I just described, the answer is going to be tonometry as the first thing you do. Okay, wrong answer. Now the correct answer is loss of balance with eyes closed. This refers to a positive Romberg sign. This patient has an Argyll-Robertson pupil, aka colloquially prostitutes pupil, accommodates but doesn't react. Okay, this is seen in neurosyphilis. Okay, it's pathognomonic for neurosyphilis. Argyll-Robertson pupil, prostitutes pupil, can accommodate in response to changes in distance, but doesn't react to light. Okay, and positive Romberg sign is because we can get tabes dorsalis, which is loss of the dorsal columns, which are responsible for vibration proprioception. But if patients have problems with the dorsal columns, they get loss of balance with the eyes closed. It's helpful for differentiating the source of ataxia. If a patient's wobbly and has a negative Romberg sign, we know the dorsal columns are intact in general, and the cerebellum is the likely etiology. Whereas if you do have a positive Romberg sign, we know the dorsal columns are very likely involved, and that's consistent with tabes dorsalis and neurosyphilis. Okay, don't confuse the Argyll-Robertson pupil here with the Marcus Gunn pupil, which is when we have a relative afferent pupillary defect. That's when you swing the light between the eyes, and you get an apparent dilation in the side that's fucked up. That's also my neuroanatomy PDF. I talk about that in more detail. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe my channel. And I appreciate your time. That's it.